Good morning, everybody. Welcome to our seminar today, Transforming the Alzheimer's Disease Journey, the Role of Geriatric Specialists in Early Diagnosis and Patient-Centered Care. My name is Dr. James Galvin from the University of Miami, Miller School of Medicine in Miami, Florida. And I really want to welcome you to this conference. We're going to show some artwork on some of the slides. I just wanted to say a little bit about the artist. Painting was created by Jane, who was an artist who developed Alzheimer's disease. And the art was provided by Elderwise, located in Seattle, and really allows people with Alzheimer's disease and related disorders to be creative and engage with each other. Just a little bio about Jane. And some of the really wonderful paintings that you'll see scattered throughout some of the slides today. Here's our agenda. I'm Dr. James Galvin, I'm the chair, and I'm going to start off by having you meet our patient, talking a little about the clinical presentation of the case. Then I'm going to introduce Dr. Anna Burke, who's going to talk a little about ensuring a timely referral and how to do assessments. And then Dr. Leslie Shaw, who's going to talk about biomarkers in order to improve accuracy and consolidate differential diagnosis. Then we're going to come back to me. We'll talk about a framework for optimizing disease care management. And then we'll have a question and answer session. Here's our obligate speaker disclosures. Just our disclaimer, this symposium was funded and organized by Biogen Global Medical. None of the faculty or the respective institutions endorse Biogen or any of its products. Its independently supported presentation is not included in the GSA or endorsed by the GSA. CME credits are not provided. Okay, the entire presentation is in accordance with US laws and regulations. All right, so let's start and keep us on time. So let's talk a little about the burden of Alzheimer's disease across North America. Roughly 6.2 million Americans are estimated to be living with Alzheimer's disease. By 2050, we're estimating 12.7 million people will be living with Alzheimer's disease. The total cost of Alzheimer's and the other related dementias are projected to be about $355 billion. And by 2050, this may be more than $1.1 trillion. Some important facts when we think about the disease and how it affects different populations, groups, and cohorts. Black Americans may be at a 2 times increased risk of Alzheimer's disease compared with whites. And older Latinx individuals are 1.5 times more likely to have Alzheimer's disease than older whites. Really, Alzheimer's disease is the leading cause of disability and morbidity in the older adults, and the long duration of disease significantly impacts public health. So what's important when we think about Alzheimer's disease, and this is going to drive home the point when Dr. Shaw talks about biomarkers later, is that while we see the patient clinically, we have to remember that the pathology cascade may begin up to 2 decades before any clinical presentation, because Alzheimer's is truly a continuum. Right? And so there's a preclinical stage where there's deposition of pathology, but no clinical symptoms, a prodromal stage where people have mild symptoms, such as mild cognitive impairment, and then finally the clinical presentation of Alzheimer's dementia. Again, you can see from this cartoon, before the onset of clinical disease, there's some neurodegeneration, neuronal injury occurring. That's about 5 to 10 years beforehand. Tau deposition maybe 15 years beforehand, and amyloid deposition possibly going back as 20 years. There are a lot of unmet needs, and we're going to try to talk about the diagnostic journey throughout this presentation. But there are a lot of unmet needs, and we have to think about these. Many individuals with early stages of Alzheimer's remain undiagnosed. These subtle cognitive change may be interpreted by many, both the lay public and, unfortunately, sometimes clinicians, as being part of the normal aging process. An accurate and early diagnosis truly is critical, right? So that we can have a prognosis, we can do advanced care planning, and we can start appropriate medications. This may all combine to reduce some of the disease burden and also the overall healthcare costs. Individuals suspected of having AD may become entangled in a cycle of continuous referrals sometimes waiting years to get a correct diagnosis, and sometimes even more years to get correct treatments. So it's really important to properly screen and manage this growing population of potential patients as the population within North America ages. We need to increase our resources. We're going to talk about that in part during the course of the next hour and a half. I also want to talk briefly about this point, and this is a particular interest of mine and the rest of the panel, and that's sort of the distinction between what's a health disparity and what's a healthcare disparity. So a health disparity really describes that there may be a higher burden of illness or disability or mortality in one group relative to another. So men compared to women, Blacks compared to whites, Hispanics versus non-Hispanics. And so there may be some underlying biological or genetic aspects to that. There's also a healthcare disparity. And this is the difference between groups in terms of access to the use of healthcare, their insurance coverage, and most importantly, the quality of care that they receive, okay? So both health disparities and healthcare disparities really change the way we have to think about the disease. And there are a lot of factors that may influence this, most of them called the social determinants of health. This includes your socioeconomic status, your age, your geographic location. If you're in a rural area, you might have less access to specialists than if you're in an urban area. Gender, sexual orientation, race, and ethnicity. So all of these factors may contribute to some of these disparities. When we think about the Alzheimer patient's journey, there are also some disparities we need to consider, right? And this goes beyond clinical care, right? So even in research, there's an uneven representation of non-white individuals in most clinical trials. There's an underrepresentation of Black older adults, Latinx older adults, Asian, and Indigenous Americans. So we don't know as much about the disease, and we don't know as much about how those individuals might respond to medications or other interventions. So race, ethnicity, socioeconomic status can affect a lot of different parts of the journey. There's a stigma associated with, there are cultural differences, how people think about the disease, how they react to the disease, how they accept the diagnosis, their disease awareness and understanding, their ability to obtain a diagnosis, and then how they're treated after their diagnosis, and what kind of access to support services they may have. The early diagnosis of Alzheimer's really has several benefits for patients, particularly if we can do this at the MCI stage. So we could potentially do some dementia prevention type of interventions, right? We can extend that window for risk factor modification. This may facilitate the prevention of further cognitive decline. We can do advanced care planning. We can plan for the future at a time when the patient can fully participate in that care planning. And we can really get the optimal access to the support and care that the patient and the family caregiver is going to need. And these three things can really help us improve health outcomes and reduce overall healthcare costs. Now, the GSA has really thought a lot about this, and they have this wonderful model called the CARE model, K-A-E-R. So K is to kickstart the brain health conversation, right? So when the provider is sitting with the older adult, to really start that first conversation, not wait for people to have signs and symptoms and show in, but how do you start that conversation? Then once you have that conversation, assess the cognitive impairment, right? Conduct a brief test. And we're going to talk about some examples of this in the upcoming presentations, right? Then we want to evaluate them, right? The E part of the model, right? So do they have a dementia? Right? And then the R part is the referral, right? So might refer to a specialist, but also referring to community resources. What's out there to help the patient? What's out there to help the family? Because the desired outcomes is really to try to improve all the health-related type of outcomes for the persons living with dementia and for their families. And the GSA has also taken a stance in involving non-physician care providers, right? So there are 7 published practice recommendations to promote this involvement. This includes nurse practitioners, social workers, physician assistants, clinical nurse specialists, physical therapists, occupational therapists, speech and language pathologists. I mean, a wider range of non-physician clinicians can really help build this. We can make information available. We can know the signs and symptoms of disease. We can listen to the person, right, and observe for signs and symptoms. We can develop and maintain routine practices. We can use brief mental status tests in order to detect this at the earliest possible perspective. We can encourage older adults whose physician has made a recommendation to follow through with that recommendation, and we can provide better support, right? And these are things we can all do together, regardless of, in the audience, what your specialty or background is. You know, when we look at the geriatrics workforce landscape, you know, it's a challenge, right? So when we project out to 2025, the supply of geriatricians and other geriatric specialists is only going to modestly increase, but the demand is going to grow much, much greater than the supply, right? This will result in about a 45% increase in demand across the USA, right? So there are just not enough geriatricians, geriatric psychiatrists, neurologists, other gerontological specialists to potentially handle the graying of America. All right, let's meet our patient, right? We really want to make this patient-centered, patient-focused presentation. So let's meet our patient. First, we're going to come back to this conceptual framework several times, and this is going to launch each of the individual talks. So as the patient enters into the journey, we're going to have a detection stage, an assessment stage, a differentiation stage, a diagnosis stage, and then a treatment and monitor stage. And so as we walk through the journey, there are going to be different patients entering at different times, and they might interact with different providers, a non-dementia trained healthcare provider, your family physician. Then there'll be also people who have more interest or more specialty trained healthcare provider, right? There might be a dementia specialist, a neurologist, a geriatric psychiatrist, a geriatrician. And then there's the broader dementia care team, which brings in all of those non-physician clinician providers. So let's start on the diagnostic journey, that patient presentation. We first want to detect it. Who possibly has disease and may benefit from treatment, right? And again, this is really starts at the beginning. This is the primary healthcare provider, the family clinician who may have a long-standing relationship with that patient. So let's meet our patient, 65-year-old woman with memory loss. She's had 2 episodes of confusion and disorientation. There is a family history of dementia involving her mother, and she also had some funny movements, choreiform movements, which are slow, writhing movements. Past medical history, significant for hypertension, gout, and urinary bladder atypia. Her laboratory tests are essentially normal, and her neurologic exam is essentially normal. It's unremarkable. Now, I'm going to turn this over to Dr. Burke, who's going to take us through the next important stage of this. Anna, take it away.
Sure. Thank you. So once we've identified a patient with some cognitive issues, potential cognitive issues, how do we ensure timely referral and assessment of these cognitive complaints? Well, it is important to note that Alzheimer's disease doesn't start when the symptoms start, right? It is a slow, insidious disease lasting years, even decades before clinical symptoms emerge. We know that many of the changes, amyloid buildup, for instance, occur 10 to 20 years before a patient ever crosses your doorstep complaining of memory loss or any other cognitive issues. So taking that into account, there are different ways that we can actually stage Alzheimer's or cognitive impairment. The NIAA research framework describes 2 clinical staging schemas. The first is a syndromal categorical cognitive staging. And this includes that stage before clinical symptoms start to emerge, where the patient still looks cognitively unimpaired. They're not complaining of any cognitive issues, any functional changes, or any significant behavioral changes. The mild cognitive impairment stage, or MCI stage, where some cognitive issues start to emerge. Perhaps the individual is starting to complain of short-term memory difficulties or more attentional deficits. But these impairments in cognition are not yet affecting their functional abilities. You may see them complaining that it takes a little bit longer to manage higher functions, like managing the finances or putting together their pill box, but they're still able to do it. Once those cognitive impairments start to affect functional abilities more significantly, they enter into what's known as the dementia stage. Now, there is also a numerical staging schema for those with Alzheimer's pathophysiological changes, those individuals who are amyloid positive. And this is essentially a staging system that includes the healthy brain aging, when people still are pretty much cognitively intact, not showing any evidence of the disease. A preclinical stage during which these underlying pathophysiological changes are starting to occur, but are not yet manifesting with clinical symptoms. The mild cognitive impairment stage, during which cognitive symptoms start to emerge but do not yet affect function. And then stages of dementia, including the mild, moderate, and severe stage, based on the level of cognitive impairment and based on the level of functional impairment that someone may experience. As we look at this NIAA research framework, it's important to understand that it still remains to be validated across diverse groups. There are many different factors that can actually affect how we diagnose these patients, how they present, and whether they're appropriately diagnosed. We know that socioeconomic status affects how these patients present. We know that years of education and the quality of education that they have undergone may actually impact some of the cognitive testing that we do as part of the diagnosis. So both high educational levels as well as low educational levels can skew test results. For an individual, for instance, who has a higher educational level and a higher cognitive reserve, they may start to experience subjective cognitive changes that are not yet picked up by standard cognitive testing. Meanwhile, somebody who has had a lower educational level may still be in the normal cognitive range, but yet test abnormally on some of the screening tests. We know that comorbid disease, including cerebrovascular disease and diabetes, also impact cognitive assessments. And limited access to healthcare also limits our ability to provide timely and efficient evaluation of these individuals. So as we get into the assessment stages, how does that assessment look? Well, first of all, the first stage of a thorough clinical assessment, whether it is done by you in the primary care or geriatric setting, or whether you choose to refer to a specialist like a geriatric psychiatrist or neurologist, the first step really does involve a thorough clinical assessment. An interview assessing where some of the symptoms are, what types of symptoms have emerged over time, how they have progressed over time. Essentially looking at a pattern of strengths and weaknesses, a pattern of onset and progression. That assessment will also oftentimes include additional testing to assess for comorbid conditions. This can include blood work, neuroimaging, assessing for for instance, metabolic or infectious issues that may be contributing to the patient's clinical picture, assessing for any kind of intracranial pathology that may be contributing to their clinical presentation. And then it will also involve a cognitive assessment, oftentimes starting off with a brief in-office cognitive screening assessment. We'll talk about some of the cognitive assessments that you can use in your office in just a moment. That may lead to a more thorough evaluation. So for instance, you or the specialist may choose to send the individual for more in-depth neuropsychological evaluation to determine, again, where the patient's cognitive strengths are, where their weaknesses may be, and if there's a pattern of cognitive strengths and weaknesses that can help determine the type of cognitive impairment that they may be dealing with. Because we do know that there are different patterns on neuropsychological testing based on the type of underlying dementia or cognitive impairment that someone is dealing with. In addition, we now have specialized testing that we can perform, whether that's genetic testing to assess for risk of developing Alzheimer's disease. These include, for instance, ApoE4 testing or testing for less common genetic mutations in presenilin genes or amyloid precursor protein genes. And then we can also do fluid biomarker testing to help bolster the diagnosis. This includes CSF studies for amyloid and tau to see if that pattern of the amyloid and tau levels is consistent with Alzheimer's, or now even blood tests for the same biomarkers. So as we assess individuals with dementia, what are some of the domains that are impacted in Alzheimer's? Well, naturally, the first is cognition. And initially, patients will present with memory complaints. So this includes impairments in working memory, episodic memory, and semantic memory. Over time, they may also develop executive dysfunction, so more difficulty with multitasking, planning, organizing information. Visuospatial functions may start to become impacted over time. So essentially how the brain processes what the eyes are seeing becomes skewed. Language abilities start to deteriorate. Initially, people will notice a short difficulty with word finding. So it may take a little bit longer, or they may have more difficulty finding a word, remembering a name. And over time, that can develop into full-blown aphasia, both expressive and receptive aphasia. Attentional abilities, praxis, all can be affected in this disease. Function also becomes affected over time. In the early stages, you see more of the instrumental activities of daily living becoming affected. This includes more difficulty, for instance, with managing the bills, managing medications, using certain appliances, driving. And then over time, as the disease progresses, more basic functions become affected, including a person's ability to bathe, dress, and even feed themselves. The one thing that we tend to forget about as clinicians, unfortunately, is the fact that Alzheimer's disease also affects behaviors. In nearly 97% of individuals with Alzheimer's disease, there is at least one change in behaviors. And this can mean emergence of anxiety, dysphoria or depression, irritability, or even agitation and aggressive behaviors. Changes in sleep patterns and circadian rhythms can start to emerge. And one of the most common symptoms of behavioral change in Alzheimer's is the emergence of apathy, a loss of interest, a loss of motivation. So how does the disease impact these domains across that Alzheimer's clinical continuum? Well, during the preclinical stages of Alzheimer's disease, a person really does not display any cognitive changes, behavioral changes, or functional changes. It's not until they enter into the mild cognitive impairment stages that you begin to see more of these cognitive issues start to emerge. Again, initially, they may complain of short-term memory difficulties, difficulty recalling words, difficulty recalling recent conversations or events. During the mild cognitive impairment stages, their function may still be intact. You may hear them complain about putting forth a little bit more effort on certain tasks or certain tasks taking longer, particularly those higher functions and instrumental activities of daily living. So they may be spending more time on paying the bills or putting together their pill box, but they're still able to do it. And you may start to see some of these slight behavioral changes like apathy, withdrawal from previously enjoyed activities, or even depressive symptoms or irritability starting to emerge. As dementia sets in, as they enter into the mild dementia stages, all of these cognitive, functional, and behavioral changes become more prominent. And then as moderate dementia starts to set in, you may see more periods of confusion, more difficulty with comprehension, with orientation, with visuospatial abilities. Their function becomes impacted to the point where they really do require more assistance with all of those instrumental activities of daily living. And we also start to see emergence of more problematic behaviors, including delusions, hallucinations, even agitation. In the severe dementia stages, the person really becomes dependent on others for most functions. They may require assistance with bathing, dressing, grooming, even eating over time. Their behavioral disturbances may become more prominent with outbursts and agitation. And confusion, including confusion as to environment or being able to even recognize those around them, starts to emerge. I won't go into detail in this slide, but it is important to note that as part of that GSA Care Toolkit, you have some examples of different assessments that you can perform that can help assess these different areas affected by the disease, including cognition, function, and behavior. However, these assessments are still a challenge because of several factors that can impact a person's performance on cognitive assessments. These include language barriers. So for instance, if you have somebody who is not a native English speaker, they may score a little bit lower on their cognitive assessment. Cultural issues, for instance, can also play a significant role in how people perform on these cognitive assessments. And then again, as I mentioned earlier, educational level, both high educational level and low educational level can also adversely impact these assessments. So let's take a look at our 65-year-old female patient. Well, how does her testing look? Well, when we performed the MMSE, she scored a 20 to 21 out of 30. She essentially lost 3 points on assessment of day and time, 1 point on place. She had difficulty with serial sevens, losing 2 to 3 points. And then on the 3-step verbal command, she had difficulty with remembering the last portion of the test and lost 1 point. She lost 1 point on copying the design and 1 point on delayed recall. When doing the clock drawing, her numbers were skewed to the right and her hands were on 11 and 10. She was only able to name 2 of the 5 presidents, and she had no behavioral or personality changes that we could ascertain. As we look at this testing, one, we are looking at the pattern on the testing. So for instance, here we see a lot of difficulty with orientation, indicating that short-term memory may start to be impacted, just as we would expect in early Alzheimer's disease. How do we interpret these results otherwise? Well, we can stage the disease using the MMSE. And there are several different staging tools that you can use or guidelines that you can use. The Alzheimer's Association provides cutoffs that you see here for mild, moderate, and severe dementia. There's a different staging tool that's used based on the Oxford medical education guidelines, and you can see that this incorporates kind of lower test scores as indicating MCI versus more severe disease. But it is important to note that the MMSE unfortunately has a low sensitivity for distinguishing mild cognitive impairment due to its lack of complexity and its lack of ability to assess for executive dysfunction. So it has not been established, or significant cutoffs have not been established for the MMSE for patients with mild cognitive impairment.
Well, thank you, Dr. Burke. I think we would like to have just a little bit of a discussion during this time. We have a few minutes. And so, I'm going to ask the question, but in the audience, think about how you might answer this question as well. So, Dr. Burke, in your practice, what tools do you routinely use to assess cognitive impairment? So if someone's coming through your door, what's your approach?
Well, we typically do an initial cognitive screening test for most of our patients. And the one that we prefer to use is the Montreal Cognitive Assessment Test for several reasons. One, again, unlike the MMSE, it is able to pick up on earlier stages of illness. So people with mild cognitive impairment will tend to score lower on the MoCA, the Montreal Cognitive Assessment Test, versus on the MMSE. They may still be testing normally on the MMSE. We also tend to see a lot of different types of dementias, and the MoCA actually includes more thorough assessments of executive function, as it includes the TRAILS-B and the clock drawing. It assesses for visuospatial deficits, for instance, again, on the clock drawing and on the copying of the cube. So it can help us assess not only people in earlier stages of illness, but also those who perhaps have different types of dementias like frontotemporal dementia or Lewy body dementia. In addition, it's important to do a behavioral screening. So we do incorporate typically the GDS or even the PHQ-9 into our practice. And from a functional standpoint, I can tell you most of us don't necessarily incorporate a specific instrument, but we do include a functional assessment, a very thorough functional assessment as part of the clinical interview. Now, after those initial assessments, depending on what the results show, many of our patients will actually be referred to a neuropsychologist for more thorough evaluation that can help us with determining the exact etiology of their symptoms.
Yeah, I think that's great. I mean, when you think about someone walking through the door, and if you're in, primary care or in gerontological, based practice, you'd like to get some assessment of their cognitive performance. And so you can choose whichever one you like. I mean, I like the MoCA as well, although it does have a little bit more educational bias. It's a harder test to do, so you have to make sure you add back the point for low education. I think assessing for mood is critical. And you're right, I think getting some sense of function. The other type of tool I would throw out there is, if available, using some type of brief informant-based assessment. So the IQ code, the AD8, the quick dementia rating system, something that allows you to collect a collateral source of information to see what the patient's really doing in the real world. Um, you know, there are challenges to do this, though, in a brief period of time. So, Dr. Burke, what are some possible challenges?
Well, I think in the specialties setting, we obviously have more time and more focus on the cognitive issues themselves. But one of the major challenges, I think, in the primary care or geriatric care setting is that unfortunately, you don't have much time. The average primary care visit right now, I think, averages about 7 to 15 minutes. And your patient is commonly not coming in because of cognitive complaints. They're coming in for you to manage their cholesterol or their high blood pressure or thyroid function. So it becomes really challenging to do a thorough evaluation. But I do think that there are tools that you can incorporate relatively easily into your clinical practice. In my work with primary care physicians, we oftentimes found that incorporating something like a mini cog into that busy practice, something that could be administered even by the medical assistant as they were doing vital signs, allowed for a more thorough screening to identify at least people with some cognitive issues. And then those primary care physicians would then either refer to a specialist like myself, or they would choose to bring the patient back for a brain health visit specifically focused on their cognitive issues. I think one of the other challenges is exactly what we talked about. A lot of these scales, also a lot of these assessments, are not necessarily appropriate for all populations. They don't incorporate or don't take into account cultural differences, language differences, educational, different levels of education. So we still have a ways to go as far as properly identifying these patients.
Yeah, I think time, like you said, is a great challenge, and then handling sort of the other possible influences of the social determinants of health are key. Dr. Shaw, I just want to pitch a quick question to you because you have a really important part coming up shortly. As we talk about all these brief screening tests, what evidence, if any, do we have that some of these things are aligning with some of the biological markers you're going to talk about in a short period of time?
Okay, so very briefly, with respect to biofluid biomarkers measurable in either cerebrospinal fluid and then more recently in blood plasma, is an ability to detect the presence, based on the testing in the biofluids, of strong evidence for either or both amyloid plaque burden by measuring A beta 42 in those biofluids, or tau burden, tau tangle burden, by measuring two forms of tau, total tau, what we call total tau, and a phosphorylated version of tau. So those tests are well developed now, mostly in CSF, but more recently in blood. So, and we'll talk more about that later on.
Okay, great. Thank you. All right. So we move on.
So, good morning. Great to be with you this morning, and we now continue the diagnostic journey in the patients that are being evaluated. We've been looking very carefully at clinical assessments of a number of different types and sorts that have been very important and informative as we assess the patient. So now, if there are certain abnormalities, then it may become important. We may be at that stage where a differential diagnosis to rule out other causes of cognitive impairment besides Alzheimer's disease. And that is where we feel the biofluid biomarkers can help. And there's no question of the value, the importance, the underlying huge importance of dementia-trained healthcare practitioners who can partner with the specialists for the ordering of the tests, for the various assessments that are made, and so on. So finally, after all of this testing is done, then enhancing our ability to make a diagnosis, confirming AD pathology, and from that, determining for the individual patient, best treatment options. So again, the dementia specialist, especially able to and equipped to focus on the diagnosis, treatment options, and hugely supported by dementia-trained healthcare practitioners, for example, neurologists. Next, please. Thank you. Thank you. A very important underlying set of principles that we've learned over the years, and this is the Cliff Jack graphical depiction of changes of several different key biomarkers, both imaging and biofluid, as well as within the patient, the occurrence of cognitive impairment. So all the way off to the right in that lightly shaded area is the zone in time for cognitive impairment, the objective observation by the various tests that our colleagues have been describing to determine that. But what we now know, based on a lot of studies in patients, especially using cerebrospinal fluid measures, as well as amyloid PET, that there's a long time period of the evolution of disease pathology detectable by abnormalities in amyloid with either CSF testing or PET, and tau measurable by CSF and especially MRI and FDG PET in terms of the imaging tests. And so you see that steady progression up to 20 years of time earlier than the first occurrence of signs and symptoms of Alzheimer's disease. Next, please. So the important point there is we're able with these biomarkers to detect the occurrence of disease before it is visible clinically, measurable clinically. So why would we use, then just kind of assembling that core information, why do we use these biomarkers, or might we use them in AD diagnosis? Of course, patients presenting with signs and symptoms of cognitive impairment is very key to rule out other causes of impairment that are commonly occur in individuals in addition to AD. So is this AD or not is helped by these biomarkers. And in addition to that is when assessed, as you saw graphically in the previous slide, monitoring disease progression, because these change in intensity over time. Next. And so again, we've been discussing earlier the NIAA research framework, and more recently an update on that research framework, where the changing landscape, I think it's a nice way to put this, of Alzheimer's disease diagnosis, moving from mostly and primarily clinical evaluations to now add into that the ability to use biomarkers to determine disease. So in a very important development, that NIAA research framework described the use of CSF testing and imaging testing, detection of amyloid abnormality and tau abnormalities in order to help stage not only detect is disease there or not by their presence, but also to stage the disease. How far along has the disease progressed? The later signs and symptoms measurable by these biomarkers, for example, MRI imaging, is a later occurrence of abnormality that we can detect, whereas measuring amyloid either by PET scan or by CSF testing, we can detect disease earlier before clinical signs and symptoms. The MRI tends to relate much more closely to clinical signs and symptoms that we measure clinically in terms of cognitive decline, things of that sort. So we're now refining the use of these tests to when they are appropriate and when they are not recommended. So for example, we're not recommending these tests as screening tests, so not recommended for cognitively unimpaired individuals, for example. We'll refine that a little bit later. Next. Thank you. So if we now consider MRI imaging and one of the hallmark later occurrences in the evolution of AD in an individual is the shrinking, the atrophying of the brain. And especially important is the hippocampal atrophy, where so many of memory functions are coordinated. And as you can see on the right, in a patient with AD dementia, a much shrunken, a much smaller hippocampus as compared to the normal control on the left. There's no question that there are, for all of these tests, advantages and disadvantages, and important to consider all of that as we move forward with the use of these tests. But brain atrophy then, well detectable and importantly detectable by MRI imaging, generally available in urban areas. We know that MRI, of course, and brain size and shrinkage and so forth is not a direct indicator of specific pathology. And a normal scan definitely does not exclude AD, but when taken together with the other piece of information, this is hugely important. Next. Another form of imaging, as you know, is PET imaging, and especially important in the evolution of our ability to detect disease in the living brain is the detection of amyloid plaque burden, a hallmark sign at the level of brain pathology of Alzheimer's disease. And so with this kind of scanning, where a radioactive fluorine-18 labeled ligand is injected into the patient, and it associates selectively with the appropriate ligand associates selectively with amyloid plaque burden, visualizable in this, the left side of this PowerPoint in the red. So the most lit up areas have the most plaque burden, and this is a highly plaque burden enriched amyloid PET scan. On the other hand, FDG PET is a very well established measure of brain sugar or glucose metabolism, again reflecting towards the right side of the Jack curve, neuronal injury and dysfunction as it proceeds down the evolution of this disease in an individual patient. It's not specific for AD, but definitely can help visualize the regions of the brain that are affected by this disease process. Next. Thank you. In terms of amyloid PET positivity, going back to that form of PET scanning, if we compare a cognitively normal image to that of an individual who's amyloid positive by PET, and in the MCI stage of the disease versus the Alzheimer's disease stage on the right, you see the evolution of the more and more intense coloration in yellow, green, and ultimately red being the hottest. Next. And then the newest form of PET that's become much more widely used over the last few years is tau PET. So visualizing tau tangle burden in the living brain is the hallmark characteristic of this form of PET scanning. Again, making use of a radio-labeled ligand specific for tau tangles. And you can see the intensity of the coloration in the brains on the right side, comparing tracer, tau tracer uptake, across the well-known and characterized stages of the disease, staged by the pathologic scheme, which we call the BRAC staging in postmortem. So in the living brain, we're able to do essentially what could only be done in the past at autopsy. Next. So the hallmark of this work, as was implied and summarized in the Jack curves, is the ability to detect disease a decade or more before clinical signs and symptoms of the disease. And that is a strong aspect, if you will, of this testing. Early detection, enabling better planning for an individual and the family, caregivers, and everyone involved. We measure in cerebrospinal fluid amyloid beta 42 peptide, reflecting amyloid plaque burden by decreasing as plaque burden increases in its solid state form of this peptide in the brain, whereas phospho-tau, phosphorylated tau, is a very sensitive and specific biomarker for Alzheimer's disease, reflecting tau tangle burden, and in CSF levels of that biomarker going up, increasing with disease progression. And total tau is a more non-specific biomarker because its abnormalities occur in other forms of disease, not just AD, but it is a marker for neurodegeneration, as is FDG PET, as we noted before. It's also true, and this is important, in evaluating these biomarkers, it turns out that the ratioing of one to the other in CSF provides an even more accurate and reliable measure of than A beta 42 alone of amyloid plaque burden, or concordance with amyloid PET, which is as we know, a measure of amyloid plaque burden. And so the ratios do become important as we refine our use of these biomarker tests. Next, please. And so this is just a depiction of these abnormalities in relation to the picture of the neuron. But the important point here is that A beta 42 levels reflecting amyloid plaque burden decrease, reflecting the increased aggregation and the solid state formation of amyloid plaques in the brain as this soluble form reaches certain concentrations. There's a tendency, because it's a very sticky protein, to coalesce, to aggregate, and to deposit, reflected by decreased A beta 42 in cerebrospinal fluid, with phospho-tau and total tau 200 to 300% increases in concentration when Alzheimer's disease pathology is present in the brain. Next. So if we compare, and this is very important for our field in terms of using these biomarkers and the practicality of using them, if we compare various aspects of amyloid PET and CSF, we know that there are pluses and minuses of both of these approaches, but cost is definitely going to play an increasingly important role, it always does, in what can get used versus not. The distribution and the availability of these is very important. So amyloid PET is thousands of dollars. Cerebral spinal fluid measure is significantly lower in cost. Radiation exposure is involved in amyloid PET, not in CSF. In CSF, one can measure several biomarkers in the same sample. With amyloid PET, it's a single type of pathology, of course. But again, amyloid PET, an excellent measure, and there are at least 3 different approved ligands for doing amyloid PET measures approved by the US FDA. On the other hand, CSF testing is now available by automated methods. There are at least 2 major ones that are currently available, one of which is at the level of FDA review and imminent, it is thought may be imminently approved, or at least approvable at this point. So these tests, that is CSF testing, is now at a very mature stage, and one can count on reliability. But a limitation for CSF is the reluctance to undergo a lumbar puncture. Either the neurologist or the doctor who's performing the procedure is not so enthusiastic about doing that, and that's understandable. And the patient may become a bit fearful about this procedure. And so that's a well-known limitation of CSF testing. Next. So with all of that background, it does make sense to consider blood-based biomarkers. Can we measure, and how reliably can we measure these biomarkers? We can measure 4240 in plasma now. We can measure phosphorylated tau, especially, as well as total tau in plasma. And there are other biomarkers in plasma that are measurable and whose methodologies are being refined. So the state of the art is that blood-based biomarkers are in a very energetic stage of their development by the vendors who develop and refine and validate these tests. And right now, for research purposes, there are several of these that are commercially available as research tests here in the United States of America. And so the emerging data is that as we increase the number of formal clinical evaluations of these tests, is we're getting closer and closer to having blood-based biomarkers that can approach, but not be equal to, but approach the accuracy and therefore the utility of CSF-based biofluid biomarkers. Next. So now we're considering further the MRI imaging assessment in this patient, the 65-year-old female patient, where we see a very strikingly hippocampal volume shrinkage, cortical gray matter, substantial volume loss. And these are depicted graphically to the right. But the important bottom line here is this is a patient whose brain has atrophied significantly and whose hippocampi have shrunk significantly, consistent with an Alzheimer's disease ultimately diagnosis. Next, please. And so just again to reinforce what these images look like, and this is an example at the top for comparison of a normal FDG PET pattern, highly lit up in red because glucose metabolism is fine, it's working well. As it diminishes, that red color now diminishes as you can see throughout this patient's brain, quite a bit, reflecting impaired glucose metabolism, again, consistent with moving towards an Alzheimer's picture in an individual patient. Next. An example of a normal amyloid scan. Often these are in color, not always, but you can see not a lot of lit up areas. On the other hand, in our patient, we see a great deal of lighting up, reflecting the binding of the amyloid ligand that's radio-labeled in this patient's brain, reflecting abnormal amyloid beta plaque burden. Next. Okay, so now we look at the CSF measures, A-beta 42, total tau, phospho-tau, and the ratio of p-tau to 42. In this patient, the A-beta 42, 720, significantly below the cutoff of 1,000 by this automated methodology. Phosphorylated tau, elevated, and as well as total tau. Again, consistent with ongoing neurodegeneration in the case of total tau, and indicative of tau pathology that is highly specific for AD on the part of the p-tau. And again, the ratio is a lot higher than the cutoff for the p-tau 42 ratio, again, consistent with an AD pathology picture. And then next. So here is our audience question. Based on these results, what would you think this clinical picture suggests? Take a moment to provide your answer to yourself. Okay, and now, as I believe the majority of you would have stated, we can look at what the diagnosis was. Yes, this is an individual with all of that data, all of the clinical testing, all of the biomarker testing, the imaging, biofluid biomarker testing, a patient with a diagnosis of mild AD dementia. The next. And so key now for the physician caring for this patient and working with the patient and caregiver is management options, refer for clinical research trial enrollment, a very important opportunity for an individual in this circumstance, and then evaluating various non-pharmaceutical interventions for stabilizing cognitive performance. Thank you.
Okay, so just to move us forward, now we want to think about what we want to do for the patient now that we've diagnosed them as living with Alzheimer's disease. And so first, we want to focus on establishing the awareness of the disease, what it is, and how the patient may benefit from care. So you want to facilitate points of entry into care, right? This could be with you, this could be with community resources, could be with, again, non-physician clinicians and other healthcare providers. Focus area 2 would be develop a patient-centered support system within the clinic, right? So in other words, how could we decrease the likelihood of patients becoming overwhelmed with this and abandoning the process of establishing their diagnosis? And then focus area 3 would be the build processing capacity for integrated care teams. So how could we alleviate some of the constraints associated with the shortage of specialists by increasing the awareness and empower the clinicians across multiple disciplines to care for the patient and improve outcomes? So focus area 1, right? So we want to educate, we want to raise awareness, right? So that's how you overcome lack of knowledge and lack of awareness, is to work together to raise it. You really want to help train the non-dementia focused healthcare providers to act and act aggressively for their patients with early stage Alzheimer's disease, to get a diagnosis and to decide what the most appropriate therapeutic options are, both pharmacological and non-pharmacological. And then you want to design an ideal process to detect patients with that early stage. Just how you can do this in your own practices and areas of interest. So again, we don't have the poll question working. So, I want you to telepathically tell me what you think about this. Which of the actions stipulated in focus area 1 do you think is of greater priority? Oh, now the poll is working. A greater priority or need to optimize patient management. 1, educate what to look for during early detection, raise awareness of the clinical value of early detection, train the non-dementia-focused HCPs to act for their patients, or design an ideal process. So for you, what do you think is the most important priority? Please check one of the answers. Give you a few seconds to do so. Next question, what channels might be most useful to establish awareness of the early detection of Alzheimer's disease amongst both the public and healthcare providers? Doing talks at local universities and colleges, online courses, social media posts, short digestible online videos, podcast, or TV or radio. No right answer. Pick what you think would be the most useful way to raise awareness of this important problem that we've been discussing. So focus area 2 is really to develop patient-centered support. How do we increase access to the services and information that the patients need, and create a care coordination team to help patients navigate their journey? So, question to the audience. Do you, in your situation, currently have a care coordination team in your clinic that you could leverage to help navigate the patient through the potential pitfalls of this new journey? Just yes, no, or if you're not sure, that's fine as well. Please take some time to answer the poll. If you have this care coordination team, it can really help facilitate patient care, and also can reduce some of the physician burden because we talked about the limited time that the physicians have in a busy clinic is 7 to 12 or 15 minutes. So using your support team would be great. Focus area 3 is to build those processes and their capacity. So establish a value case, right, to develop cross-functional teams, right, value-based care, and to educate future physicians and providers to be dementia trained, so they're more empowered to address this rising problem. Again, another audience question. Again, this is really useful, helps us sort of think about how each of you are addressing this problem. Based on this proposed framework, what do you think is the greatest challenge facing the management of early stage Alzheimer's disease? The public awareness about importance, education of healthcare providers, patient engagement with access to service, the access to specialists, the access to biomarkers, or the need for a defined step-by-step process that takes people from detection to diagnosis? Again, pick an answer for me. So when we think about expanding access to the diagnostic tools and complementing assessments with biomarkers, right? Biomarkers are going to change the way we approach the disease, and that's why we wanted to spend some time talking about that. It will be essential to educate the non-dementia trained healthcare providers to detect and support the patient. They might refer to dementia trained healthcare providers who could reduce the burden on the specialists because there is a dearth of neurologists, geriatricians, and geriatric psychiatrists. So really, this is going to be the job of all healthcare providers, regardless of their specialty. And so how could they administer a valid test and possibly order a biomarker, particularly with the advent of plasma biomarkers? The testing should incorporate some cognitive assessment, some thought about how you're going to look at function, look at mood and behaviors, and how we're going to take a clinical history to help us make diagnoses. Okay, this will lead or increase the access to the correct multidisciplinary care team for that patient, right? How do we provide all the different services in the maximal efficiency? And it's important to communicate the full scope of services that may be available in the community so that patients can flow from place to place and that information can potentially flow with them. Biomarker testing is going to change the way we approach this disease, right? PETs are available, but they're expensive. CSF tests may be used as an alternative to PET imaging and may be a more readily expandable service, but people are afraid of spinal taps and some physicians are unwilling to do them. I think blood-based biomarkers hopefully will be widely available in the near future, and maybe really the triaging as a first step for how we determine where people are going to go next. So when we think about what's currently available in the USA, CSF biomarkers are available, but you do have to justify their usage based on patients' symptoms and specific criteria. The Alzheimer Association has developed an appropriate use criteria for CSF biomarkers. Now, Medicare reimbursement is somewhat limited for these tests, and it does vary a little from state to state. The lumbar punctures are universally covered as a medical procedure. The coverage of the biomarker analysis may vary depending on which lab you're using, what insurance company the patient has, other state variations. Plasma biomarkers, there is a beta 42 to 40 ratio blood test commercially available. But it's not currently reimbursed by insurance providers. There is a sliding scale, so there are some options available, but again, it's not reimbursed. Plasma phosphorylated tau has the potential to be used clinically, but again, is not yet commercially available. So we're a little farther behind, but this may change the way we think about disease, but particularly for that early triaging. And of course, amyloid PET, as Dr. Shaw alluded to, is available. It's quite good, but it's expensive. Right? And so usage should be justified by the patient's symptoms and criteria. And the Amyloid Imaging Task Force have developed recommendations about how you can use this. But again, it's not currently reimbursed in the US. So these are all challenges to how we incorporate biomarkers into our practices now. But I think it's important to discuss so we can begin to think about how we will be able to incorporate them in the future. So I'm going to pitch this out to the panel. So what are some of the current barriers to the biomarker assessment? So Dr. Burke, let me ask you from a clinical perspective. In clinical practice, what are some of those barriers that you see?
Well, several factors. I mean, I think Dr. Shaw already mentioned one of these barriers, which is that we have patients in different regions of the country, right? An amyloid PET scan may not necessarily be available if you're out in the middle of nowhere or in a smaller town or clinical care setting. So that's one of the limits. The other is some hesitancy to undergo this type of testing. We know that lumbar punctures, even though they are available, are still viewed by some patients and families as being very invasive, and they may not necessarily want to undergo that type of testing. Again, I think cost obviously plays a role as well. Many patients can't afford to undergo a $4,000 amyloid PET scan as part of their workup, and even going through a lumbar puncture, which may cost several $100s as far as the assay goes, may be cost prohibitive for many families.
Right. No, I agree with you. Dr. Shaw, what do you think the future holds for plasma biomarkers?
Sorry about that. Can you hear me? Okay. So there is a major commitment on the part of the vendors who make these tests, who manufacture them, who standardize them, in concert with the biomarker researcher community in various academic centers, for example. So not only here in the US of A, but especially in Europe, Australia, and other parts of the world, it's happening. The development is being done, the studies are being done, but it does take a period of time to properly do these studies and scientifically validate their utility in a world that is very complex. AD is not a simple disease as we know, as everyone knows. It's complicated pathologically in terms of co-factors in addition to amyloid and tau pathology. Having said all that, plasma biomarker developments are rapidly occurring, and I anticipate within the next year or two, the first submission to the FDA, the 4240 test that Dr. Galvin referred to is now available as a laboratory developed test, and it works very, very well, I can say technically. So we're moving rapidly, Jim, and we expect these to be available widely in the near future.
Great, thank you, Dr. Shaw. So I'm going to take the chairman's prerogative and move forward. So I think this has been just an amazing experience. You know, I think we covered a lot of topics. I want to thank my panelists, Dr. Burke and Dr. Shaw, for, you know, really giving outstanding presentations, and we tried to get as many of the questions as we can. I want to thank our sponsor, Biogen, for sponsoring this. I want to thank GSA for allowing us the opportunity to present what I hope you thought was an informative and educational program. Again, I want to wish you all a great meeting. I know it's been a good meeting so far, and I hope you enjoy the rest of your meeting time. Thank you, thank you, thank you. Have a great day.